Welcome to today's episode where we're going to talk about the global burden of cancer and why it's such a huge challenge for healthcare systems worldwide. I'm going to keep things simple so everyone, especially medical students, can follow along. So, cancer is a major problem around the world, and it's the third leading cause of death globally. By 2030, we expect 26 million new cases of cancer and 17 million cancer related deaths every year. That's a massive number. What's especially concerning is how much cancer affects developing countries. Back in 2008, more than half of all new cancer cases and three-quarters of cancer deaths were in developing nations. The reason for this is that these countries often don't have the resources like proper healthcare systems, specialists, or even basic cancer treatments, making it harder to fight cancer effectively. In many cases, people can't access screening or early diagnosis, which means cancer is often found too late. This is where the World Cancer Declaration comes in. In 2009, the Union for International Cancer Control launched this initiative with 11 important goals to improve cancer care and prevention globally. These goals focus on things like 1. Ensuring sustainable cancer care in all countries, 2. Reducing tobacco and alcohol use as well as obesity, 3. Vaccinating people against hepatitis B and HPV, which are linked to certain cancers. 4. Providing better cancer screening and early detection. 5. Improving public awareness and understanding of cancer. 6. Ensuring access to pain relief, especially in low income countries. The issue is even more serious in poorer countries, where the survival rate for cancer is much lower. In high income countries, the survival rate can be as high as 56%, but in the poorest countries, it's only 25%. This means prevention is critical. Preventing cancer is the most cost effective way to reduce deaths. Let's talk about tobacco. It's the leading cause of cancer that's avoidable. Tobacco causes about 3 million cancers each year, including lung, bladder, and throat cancers. Around 1.3 billion people worldwide smoke, and smoking is particularly high in men from places like Eastern Europe and China. It's also the main reason lung cancer is the most common cancer globally. In fact, cigarette smoking causes about 20% of all cancer deaths. The good news? Quitting smoking can prevent a lot of these cancers. Now let's talk about lifestyle factors. Things like obesity, lack of physical activity, and poor diet can also lead to cancer. A diet high in fat, red meat, and processed foods has been linked to cancers of the stomach, liver, and colon. On the flip side, eating more fruits, vegetables, and fiber can lower the risk. Obesity is a growing problem, especially in children, and it's not just an issue in wealthy countries, it's spreading to lower income nations as well, due to more processed foods and less exercise. Infections also play a big role in cancer. Chronic infections like HPV, Helicobacter pylori, which causes stomach ulcers, and hepatitis B and C can lead to cancers like cervical cancer, liver cancer, and stomach cancer. These infections are more common in developing countries, where they cause a lot of cancer cases. For example, cervical cancer is the fourth leading cause of cancer deaths in women, and most of these cases are in developing countries. There is hope, though, as vaccines for HPV and hepatitis B are available, and they can reduce the number of cancer cases. In fact, Rwanda has already started vaccinating girls against HPV and screening for cervical cancer. But cancer prevention isn't just about vaccines, it's also about education. In areas where people have low literacy rates and little access to healthcare, teaching people about cancer can help with early diagnosis, better screening, and more acceptance of treatments. Finally, we can't forget about treatment. In many low income countries, access to cancer treatment is very limited. This includes things like surgery, radiation, and chemotherapy. New treatments are expensive, and poor countries can't always afford them. That's why it's so important to make treatments affordable and accessible. For many people, cancer can't be cured. Palliative care is vital. This is about managing symptoms and improving quality of life. Unfortunately, access to pain medication like morphine is very limited in many developing countries. In some parts of Africa, people have to travel long distances just to get a few days' worth of pain relief. In conclusion, cancer is a huge challenge worldwide, but there are things we can do to help reduce the burden. Prevention, education, and improving access to treatment and pain relief are key. It's a global problem, but with the right strategies, we can make a real difference in fighting cancer. Thanks for listening today. If you have any questions or thoughts, feel free to reach out. Let's continue our discussion on cancer. And now we're going to talk about how doctors actually diagnose cancer. When a cancer diagnosis is made, it's usually done by looking at tissue samples under a microscope. This is called a histological assessment. The tissue sample could come from a biopsy, where a small sample of tissue is taken, or from a resected specimen, which is tissue that has been surgically removed. It's really important that the results of these tests are discussed carefully by a team of doctors, including oncologists, cancer specialists, and pathologists, doctors who study tissue samples. The goal is to understand the cancer fully and make the best treatment plan for the patient. So, what are pathologists looking for when they examine a tissue sample under the microscope? There are several key features of cancer cells, which are different from normal cells. Some of these include: one, abnormal cellular morphology. This means that the cells look different from normal healthy cells. Two, increased rate of mitosis. Mitosis is the process of cell division. Cancer cells divide much faster than normal cells. Three, multinucleated cells. These are cells that have more than one nucleus, which is abnormal. Four, increased nuclear DNA and nuclear to cytoplasmic ratio. The nucleus in cancer cells is usually larger, and the DNA is often more abnormal. Five, disorganized tissue architecture. The normal structure of tissue gets messed up in cancer, making the tissue look less organized. The pathologist will also look for other signs like the tumor size, whether cancer has spread to nearby lymph nodes, and if there is any sign of lymphovascular invasion, where cancer cells spread through the lymphatic or blood vessels. When a tumor is still confined to its original tissue and hasn't spread into surrounding areas, it's called in situ cancer. In situ means in place, and these tumors are non-invasive. While they show all the other signs of cancer, they haven't yet invaded the tissue around them. This is considered an early stage of cancer. Tumor nomenclature, naming tumors. When doctors name a tumor, they use a few key suffixes. Oma means a benign tumor, which is usually not cancerous. For example, a lipoma is a benign tumor of fat tissue. Carcinoma is used for malignant cancerous tumors that come from epithelial tissue, which is the tissue that covers surfaces in the body like skin, organs, etc. For example, adenocarcinoma is a type of cancer that comes from glandular tissue. Sarcoma refers to malignant tumors that come from connective tissues like bone, muscle, or fat. For example, osteosarcoma is a cancer of bone tissue. Doctors also use prefixes to describe where the tumor originated. For example, adeno means the tumor is from glandular tissue, like in the liver or pancreas. Osteo means the tumor comes from bone tissue. Lipo refers to fat tissue. Angio refers to blood vessels. Sometimes cancers can have more than one type of tissue involved. For example, carcinosarcoma is a tumor that has both epithelial and connective tissue cancer cells. When doctors can't fit the cancer into a known category, it's often called carcinoma nos, not otherwise specified. Tumor grade. Now let's talk about how doctors assess the aggressiveness of a tumor. This is called grading. Tumors are graded based on how much they resemble the normal tissue they came from. The more the cancer looks like the normal tissue, the lower the grade and the less aggressive it tends to be. The grading scale is usually 1 to 3. Grade 1 means the tumor is well differentiated. This means the cells look quite like the normal tissue and the tumor is usually less aggressive. Grade 3 means the tumor is poorly differentiated. The cells look very different from the normal tissue and the tumor is usually more aggressive and fast growing. Sometimes, a tumor is so poorly differentiated that doctors can't even tell what type of tissue it came from. These tumors are called anaplastic, which means they are so abnormal that they don't resemble any normal tissue. The importance of tumor grade. The grade of a tumor is important because it helps doctors predict the prognosis, meaning how likely it is that the patient will recover or respond to treatment. Tumors with a lower grade, like grade 1, tend to have a better prognosis, meaning they grow slower and are easier to treat. Tumors with a higher grade, like grade 3, are more aggressive and harder to treat. However, grading isn't always perfect. Sometimes cancer can look different in different parts of the same tumor. This means that a single tumor could have areas with different grades. For example, part of the tumor might be well differentiated, grade 1, while another part is poorly differentiated, grade 3. That's why it's so important to take enough tissue samples to get an accurate idea of how aggressive the cancer is. Conclusion. In summary, diagnosing cancer involves looking at tissue samples under a microscope and identifying features like abnormal cell growth and changes in the tissue structure. Tumors are named and classified based on their tissue origin, and their grade helps doctors predict how aggressive the cancer is. Understanding the histological features of cancer helps doctors make the right treatment decisions and guide the patient's care. That's it for today's episode. I hope this breakdown of tumor diagnosis, naming, and grading helps make things clearer. If you've got any questions or need more details, feel free to reach out. Let's continue discussing some diagnostic tools and concepts that help us understand cancer better. Cytology. Cytology is the study of cells and can be very useful for diagnosing cancer, especially when a doctor performs a fine needle aspiration, FNA, where a small needle is used to take a sample from a lump or mass. It's also used in cases where fluid is collected from areas like the chest, pleural fluid, abdomen, ascites, or the brain and spinal cord, CSF. By examining the cells in these fluids, doctors can sometimes diagnose cancer, but there are some limitations. For example, sampling errors can lead to false negative results, meaning the test might miss cancer even when it's there. On the other hand, active infections or abscesses can cause false positive results, where the test suggests cancer when it's not present. In cytology, we look for specific changes in the cells that suggest cancer, like increased mitosis, more cell divisions than normal, altered cell shape and size, pleomorphism, changes in the cell nucleus, such as it being larger or having an uneven shape. These abnormalities help doctors identify cancer cells and determine if the tumor is malignant, cancerous. Cytogenetic analysis. Cytogenetics looks at the chromosomes in cancer cells. Some cancers have specific changes in chromosomes that can be used to help diagnose them. For example, using a test called fluorescent in situ hybridization, FISH, doctors can look for particular chromosomal abnormalities that are common in certain cancers. A well-known example is Ewing's sarcoma, where there's a chromosome translocation between chromosome 11 and 22. Understanding these genetic changes can help doctors identify the cancer more accurately and sometimes guide treatment decisions. Tumor stage. When it comes to cancer, we also need to know the stage, which tells us how far the cancer has spread. The most commonly used system is the TNM classification. T stands for the size of the primary tumor, N represents the lymph nodes affected, M indicates if the cancer has spread to other parts of the body, metastasis. This system helps doctors understand the extent of the disease and plan the treatment accordingly. Performance status. Another important factor in treating cancer is understanding the patient's performance status. This refers to how well the patient is able to do daily activities like taking care of themselves and moving around. It's measured using scales like the ECOG, Eastern Cooperative Oncology Group, and Karnofsky scales. The performance status is critical because it can help predict how well the patient will tolerate treatment. Patients with a higher performance status, like or 1, can usually handle treatments better, while those with lower performance status, like 3 or 4, may not tolerate treatments as well, and sometimes treatments might even make their condition worse. In summary, tools like cytology, cytogenetic analysis, tumor staging, and performance status are all crucial for diagnosing and managing cancer. They help doctors determine the nature of the tumor, how far it has spread, and how best to treat the patient. Let's dive into how environmental factors play a big role in cancer development. Most cancers are caused by a combination of genetic factors and environmental carcinogens, cancer-causing substances. Epidemiological studies, which look at cancer patterns in different groups of people, help us understand these triggers. Some cancers are linked to one main cause, while others develop because of multiple factors working together. Radiation, one major environmental factor, is radiation. There are two types: ionizing and non ionizing radiation. Ionizing radiation has very high energy and includes things like gamma rays from space, radon gas from the ground, and X rays from medical scans. This kind of radiation can damage cells and DNA by knocking electrons out of atoms, causing the atoms to become unstable. Some tissues, like bone marrow, thyroid, and breast tissue, are especially sensitive to ionizing radiation. Non ionizing radiation has lower energy and includes things like ultraviolet UV radiation from the sun and radiofrequency radiation from electronic devices. UV radiation, especially UVB, is harmful because it can cause changes to the DNA in skin cells. These changes can lead to skin cancer if the DNA is not repaired properly. For example, people with a condition called xeroderma pigmentosum, which affects DNA repair, are more likely to develop skin cancer when exposed to UV rays. Additionally, people with lighter skin are more vulnerable to UV damage because they have less melanin, which helps protect the skin from radiation. Chemicals. There are many chemicals that can cause cancer called carcinogens. These work in three stages: initiation, promotion, and progression. Initiation happens when a carcinogen damages DNA and the cell cannot repair it. A single exposure to a carcinogen can trigger this stage. Promotion is reversible but involves repeated exposure to the carcinogen. It causes certain cells to grow uncontrollably without directly changing their DNA. Progression is the final stage where the cancer becomes irreversible. It involves further DNA damage, leading to more abnormal cell growth that is detectable under a microscope. Some common chemicals that act as carcinogens include vinyl chloride, aflatoxins, and substances found in nitrosamines. Smoking is one of the most well-known causes of cancer. The chemicals in tobacco smoke can cause cancer, especially in the lungs, mouth, throat, esophagus, and bladder. In fact, 90% of lung cancer cases are caused by smoking. Smokers have a much higher chance of dying from lung cancer compared to non-smokers. Even people who are exposed to secondhand smoke are at increased risk of cancer. Interestingly, smoking seems to lower the risk of endometrial cancer, cancer of the lining of the uterus, though it increases the risk of many other cancers. In short, cancer often arises from environmental factors like radiation, chemicals, and smoking, which either damage DNA or cause abnormal cell growth. Understanding these factors can help in prevention and early detection of cancer. Infections play a major role in the global burden of cancer, contributing to around 1.5 million cancer cases each year, including cancers of the cervix, stomach, liver, bladder, and lymphomas. The connection between infections and cancer was first discovered in 1911 by Peyton Rouse, who studied how viruses could cause cancer in chickens. Certain viruses are known to increase the risk of cancer. For example, people with HIV, which weakens the immune system, are at higher risk of developing cancers caused by herpes viruses, such as Kaposi sarcoma and Castleman syndrome, often seen in HIV-positive individuals. The Epstein-Barr virus, EBV, is linked to cancers like Hodgkin's lymphoma and Burkitt's lymphoma, while the human papillomavirus, HPV, especially types 16, 18, 31, and 45, is a major cause of cervical cancer. Similarly, hepatitis B and C viruses are known to cause liver cancer, hepatocellular carcinoma. Some parasites also contribute to cancer. For example, malaria is associated with Burkitt's lymphoma, and schistosoma infections are linked to cancers of the bladder, liver, and colon. Chronic infections like tuberculosis can also increase the risk of developing cancer, likely due to long-term inflammation. Now let's talk about hormones. Both natural, endogenous, and synthetic, exogenous hormones can influence cancer risk. For example, breast cancer risk is linked to prolonged exposure to estrogens. Factors like having fewer children, starting menstruation early, or going through menopause late can increase exposure to estrogens, raising cancer risk. Interestingly, the combined oral contraceptive pill, COCP, doesn't increase breast cancer risk as it's used during times when estrogen levels are naturally higher. For ovarian cancer, the risk is related to the number of times a woman ovulates. Nulliparity, having no children, increases the risk, but using the COCP for 10 years or more can reduce the risk by 50%. In postmenopausal women, estrogen only hormone replacement therapy, HRT, can increase the risk of endometrial cancer. Finally, nutrition and lifestyle factors play a huge role in cancer risk. Around 30% of cancers are thought to be linked to poor nutrition, and obesity is a major risk factor for many cancers. Alcohol consumption is another key factor, particularly in cancers of the GI tract, liver, breast, and ovary. Alcohol increases the risk by causing oxidative stress and prolonged exposure to acetaldehyde, a harmful substance produced when alcohol is broken down in the body. For people with liver cirrhosis caused by alcohol, the risk of liver cancer is also much higher. Interestingly, lifestyle changes, such as migration from a low risk area to a high risk area, can influence cancer risk. For example, women who move from Far Eastern countries to Western countries may see their risk of breast cancer increase over generations, approaching the rates of the local population. Cancer is a complex and gradual process that starts with genetic mutations in cells. These mutations accumulate over time, and eventually they lead to cancer. To understand how cancer forms and spreads, researchers have identified certain characteristics that cancer cells must acquire. These are known as the hallmarks of cancer, and today we're going to discuss two of them: genome instability and mutation, and resisting cell death. Genome instability and mutation are at the core of cancer development. Every time a cell divides, its DNA is copied. During this process, mistakes, mutations, can happen. Most of the time, the body has mechanisms to fix these mistakes, but in cancer cells, these repair systems may not work properly. As a result, more mutations accumulate, and this process accelerates in cancer cells. These mutations can give the cancerous cells a growth advantage, allowing them to overgrow and dominate the tissue. Over time, as more mutations pile up, they drive the progression of cancer. So, genomic instability makes cancer cells more prone to further mutations, speeding up the process of carcinogenesis. The second hallmark is resisting cell death, which is crucial for cancer to survive and grow. In normal tissues, when cells are damaged or dysfunctional, they undergo apoptosis, or programmed cell death. This is a natural process that helps the body get rid of unwanted or dangerous cells. However, cancer cells often develop the ability to resist apoptosis, meaning they don't die as they should. Instead, they continue to survive, grow, and divide. This resistance to cell death is one of the reasons cancer cells can grow uncontrollably. Apoptosis is regulated by a complex system in the cell. There are sensors that detect signals from inside and outside the cell, and if something is wrong, they trigger a cascade of events that leads to cell death. This involves breaking down the cell's structure, including its DNA and cell membrane, which is then cleared away by neighboring cells. In cancer, this process is often disrupted, allowing abnormal cells to survive longer than they should. In short, cancer cells have to break the rules of normal cell function to survive and grow. Genomic instability allows them to acquire more mutations, and resisting cell death ensures they don't get eliminated by the body's natural defense systems. These two hallmarks are just the beginning of understanding how cancer develops, but they give us important insights into how cancer cells behave and how we might target them in treatments. When we talk about cancer cell survival, a key concept is apoptosis, or programmed cell death. Apoptosis is a natural process where cells that are damaged or no longer needed are removed by the body. In cancer, however, this process is often disrupted, allowing cancer cells to survive and continue growing. Apoptosis can be triggered by several factors. For example, the removal of survival signals like IL-3 or IGF-1 can lead to cell death. This is especially important during development, where cells need to be in the right place at the right time. If they are in the wrong place, they will undergo apoptosis to prevent abnormalities. But in cancer, the pathways that regulate apoptosis are often broken. One of the main regulators of apoptosis is a gene called TP53, often called the guardian of the genome. TP53 can sense DNA damage, and if it's severe enough, it triggers apoptosis to prevent the damaged cell from becoming cancerous. However, in many cancer cells, TP53 is either mutated or lost, which disables this protective mechanism. Without TP53, cells with damaged DNA can continue to divide and grow, leading to cancer. In addition to losing TP53, cancer cells can void apoptosis in other ways. They might increase the levels of anti apoptotic proteins like BCL2 or reduce the levels of pro apoptotic factors like BAX and PUMA. These changes help cancer cells resist the normal signals that would trigger cell death. Another process involved in cancer cell survival is autophagy. Autophagy is when a cell breaks down its own components to recycle nutrients, especially during times of stress like nutrient starvation. It can be helpful for cancer cells because it allows them to survive in tough conditions, such as when they don't have enough oxygen or nutrients. Surprisingly, treatments like chemotherapy or radiation can actually increase autophagy in cancer cells, which can help them survive and recover from stress. This is why some tumors may shrink temporarily but then regrow after treatment. On the other hand, there is also necrosis, which is an uncontrolled form of cell death. Unlike apoptosis, where the cell disassembles itself in a controlled way, necrosis leads to the spilling of cell contents into the surrounding tissue. This causes inflammation, which can attract immune cells to the area. These immune cells can sometimes promote cancer by encouraging angiogenesis, the growth of new blood vessels, cell proliferation, and tissue invasion, all of which can help the tumor grow and spread. In summary, while apoptosis is the body's way of eliminating damaged or unneeded cells, cancer cells find ways to avoid it, helping them survive. Autophagy and necrosis also play roles in cancer survival and progression, making cancer treatment even more challenging. One of the key features of cancer cells is their ability to keep growing and dividing uncontrollably. Normally, the body has a strict system in place to regulate cell growth and division, ensuring that cells only divide when necessary. This regulation is controlled by various growth promoting signaling pathways. In cancer cells, however, these pathways become deregulated, leading to uncontrolled proliferation. The most common way this happens is through growth factors, which are molecules that bind to receptors on the surface of cells. When a growth factor binds to its receptor, it activates a signal inside the cell that triggers gene expression and leads to cell division. Cancer cells may find several ways to keep this process going beyond normal levels. Some of these ways include 1. Overproduction of growth factors. Cancer cells may make too many growth factors, leading to constant stimulation for cell division. 2. Overproduction of growth factor receptors. If there are more receptors on the cell surface, even normal levels of growth factors can result in excessive cell division. 3. Altered receptors. Some cancer cells produce receptors that can send signals even without the growth factor binding to them. 4. Activation of internal signaling pathways. Cancer cells may bypass the need for growth factors entirely, activating internal pathways that drive cell division continuously. Now let's talk about the cell cycle. The cell cycle is the process by which a cell grows and divides. It's divided into four phases: G1, growth; S, DNA synthesis; G2, preparation for mitosis; and M, mitosis, where the cell actually divides. Normally, cells stop growing when they've reached a certain density or when they don't have enough nutrients. In this state, the cell enters G0, where it's inactive but can be triggered to restart if needed. During the G1 phase, cells prepare for DNA replication. There's a restriction point in G1 where the cell decides whether to continue to the next phase or stop. Once the cell passes this point, it's committed to DNA synthesis in the S phase. The cell then enters G2 to repair any DNA errors before moving into M phase to divide. Cell cycle progression is tightly regulated by proteins called cyclins and cyclin-dependent kinases, CDKs. These proteins act like checkpoints, controlling the transition from one phase to the next. Tumor suppressor genes like TP53, the guardian of the genome, are important because they can stop the cell cycle if there's DNA damage, preventing the cell from dividing and passing on mutations. If these tumor suppressor genes are lost or mutated, the cell cycle can go out of control. Cancer cells often bypass these checkpoints. They ignore growth inhibitory signals and don't stop for repairs, allowing them to replicate damaged DNA. This accumulation of mutations gives the cancer cells a proliferative advantage, helping the tumor grow faster. This understanding of the cell cycle has been crucial in developing cancer treatments. Chemotherapy drugs, for example, target rapidly dividing cells. Some drugs interfere with DNA synthesis during the S phase, while others disrupt the process of cell division during M phase. However, some chemotherapy drugs are nonspecific and can affect cells throughout the entire cycle, not just those dividing. In short, cancer cells have figured out how to bypass the normal regulatory systems of the cell cycle, leading to uncontrolled growth. Understanding this has led to many treatment options that target these weaknesses in cancer cells. Cancer cells often manage to stimulate their own growth through a process called autocrine stimulation. This means that they produce their own growth factors, which then trigger further cell division in a positive feedback loop. A couple of examples of these growth factors are TGF-A and PDGF. This helps the cancer cells bypass the normal controls that regulate how and when cells should divide. In healthy cells, progression through the G1 phase of the cell cycle into the S phase is tightly controlled by proteins like cyclin D, cyclin EC, cyclin TC, and cyclin A. These proteins help the cell move forward in the cycle. In cancer, however, this regulation can go awry. Cancer cells might either produce too many growth factors, like in the case of autocrine stimulation, or they may have too many growth factor receptors. These receptors can be either overproduced or mutated to constantly send growth signals, even without the presence of the actual growth factor. For instance, TISH EGFR is often overexpressed in lung and gastrointestinal cancers, and HER2 is frequently overexpressed in breast cancer. Both of these receptors activate the RAS-RAF-MAP kinase pathway, promoting cell division. Understanding this process has led to new treatments that target these specific receptors. Another common mutation seen in cancer is in the RAS gene, which is found in about 30% of all cancers. Mutations here can lead to the constant activation of pathways that cause abnormal cell growth, even in the absence of growth signals. In addition to stimulating their own growth, cancer cells can also evade growth suppression signals. In normal cells, proteins like TP53 and RB act as brakes on the cell cycle. These tumor suppressors can stop the cell cycle or trigger cell death if the DNA is damaged or if the environment isn't right for cell growth. But in cancer cells, these brakes are often disabled. For example, PRB normally prevents the cell from moving from G1 into S phase. But in cancer, mutations in this pathway can cause the cell to bypass this checkpoint and continue dividing, even if the DNA is damaged. Healthy cells also rely on contact inhibition. When cells get too crowded, they stop dividing. Cancer cells often lose this ability, allowing them to grow in dense clusters without stopping. Telomerase is another key player in the immortalization of cancer cells. Normally, the ends of chromosomes, called telomeres, shorten each time a cell divides, which eventually leads to cell death. However, in cancer cells, telomerase is often reactivated. This enzyme rebuilds the telomeres, allowing the cell to keep dividing endlessly. Most normal cells don't have active telomerase, but many cancer cells do, which is one of the reasons why cancer cells can proliferate indefinitely. In summary, cancer cells have several ways to overcome normal growth controls. They can stimulate their own growth, evade suppression signals, and maintain their ability to keep dividing indefinitely. This understanding has paved the way for therapies that target these specific mechanisms to try and stop the uncontrolled growth of cancer. Cancer cells can't grow beyond a certain size without a proper blood supply, and this is where angiogenesis comes into play. Angiogenesis is the process of creating new blood vessels, and it's crucial for tumors to get the nutrients and oxygen they need, while also removing waste products like carbon dioxide. In healthy adults, the blood vessels are usually stable and don't grow unless needed, like during wound healing or the menstrual cycle. However, cancer cells take advantage of this process. They send out signals that trigger the growth of abnormal blood vessels, which are different from the normal ones. These vessels are irregular, often leaky, and they don't work properly. They can also bleed inside the tumor, which can make the tumor environment more chaotic. The growth of new blood vessels in tumors is driven by special angiogenic growth factors, with the two most well-known being VEGF, vascular endothelial growth factor, and PDGF, platelet-derived growth factor. These signals activate what's called the angiogenic switch, causing the tumor to continue growing its blood supply to meet its needs. But this process is also tightly controlled by a balance between stimulating factors and inhibitors. For instance, TSP1 is an inhibitor that can block angiogenesis by sending signals that suppress blood vessel growth. Interestingly, many different types of cells contribute to this process. For example, pericytes, which are cells that wrap around blood vessels, help stabilize the growing blood vessels. Additionally, certain bone marrow derived cells like macrophages, neutrophils, and mast cells help support angiogenesis by releasing growth factors and other signals that encourage the formation of new blood vessels. Because angiogenesis is so critical for tumor growth, scientists have developed drugs to block this process. Drugs like bevacizumab, an antibody against VEGF, and sunitinib, a small molecule inhibitor of the PDGF receptor, are used in the treatment of various cancers. Bevacizumab has been shown to improve survival in cancers like colon, breast, and ovarian, while sunitinib is used for cancers like renal cell carcinoma and gastrointestinal stromal tumors. So, by targeting the blood vessels that feed cancer, these therapies aim to starve the tumor, preventing it from growing and spreading. In cancer, the process of invasion and metastasis is how cancer cells spread from their original location to other parts of the body. This is a multi step process that starts with the cancer cells invading the nearby tissue. They then enter blood or lymphatic vessels and travel through the bloodstream or lymph to distant organs where they form micrometastases, tiny clusters of cancer cells that grow into larger macroscopic metastatic lesions. As cancer cells spread, they undergo several changes that help them move and invade. One of the key changes involves their cell shape and how they attach to neighboring cells and the surrounding extracellular matrix, the network of molecules that support cells. A protein called cadherin 1, or E-cadherin, plays an important role in keeping cells stuck together. Normally, cadherin 1 helps form organized cell sheets, and when it's present in tumors, it can help prevent the cells from invading nearby tissues. However, in many cancers, cadherin 1 expression is reduced or lost. This loss can be due to mutations in the CDH1 gene, which is linked to cancers like gastric, breast, colorectal, thyroid, and ovarian cancer. When cadherin 1 is lost, the cells are less able to stick together, making them more mobile. This allows the cancer cells to break through the tissue's basement membrane and invade surrounding areas. For example, in breast cancer, tumors that are more invasive, like invasive lobular carcinoma, often have much lower levels of cadherin 1 for compared to non invasive forms, like invasive ductal carcinoma. Pathologists use this difference to help identify and classify the types of breast cancer. Another key process in cancer cell invasion is called the epithelial mesenchymal transition, EMT. During EMT, the cancer cells change from a more stable, stationary epithelial state to a more mobile, mesenchymal-like state. This transformation allows cancer cells to invade new areas and resist normal cell death, apoptosis, helping them spread throughout the body. The surrounding stromal cells, the support cells of the tumor, also play a big role in promoting invasion and metastasis. For example, mesenchymal stem cells in the tumor stroma release a protein called CCL5, which helps recruit immune cells to the tumor. This can stimulate cancer cells to invade even more. Macrophages, a type of immune cell, can also help by secreting enzymes that break down the tissue matrix, making it easier for the cancer cells to move. In summary, cancer cells can invade and spread by changing how they interact with other cells, losing adhesion molecules like cadherin 1, and using help from surrounding cells to break down tissue barriers. These processes are key for metastasis, and understanding them is crucial for developing better treatments to stop cancer from spreading. Cancer cells don't just rely on uncontrolled growth, they also need to make significant changes to their energy metabolism to sustain their rapid division. Normally, cells use two types of processes to make energy: oxidative phosphorylation, which happens in the mitochondria when oxygen is available, and glycolysis, which happens in the cytoplasm when there's no oxygen. Under normal conditions, glycolysis is less efficient, producing less ATP, energy, than oxidative phosphorylation. However, cancer cells often switch to a process called aerobic glycolysis, where they mainly rely on glycolysis to produce energy, even when there's plenty of oxygen. This process seems counterintuitive because glycolysis produces far less energy compared to oxidative phosphorylation. But here's the catch. Even though aerobic glycolysis doesn't make as much ATP, it helps the cancer cells by producing more glycolytic intermediates, molecules that can be used in other important pathways, such as those that create nucleosides for DNA and amino acids for proteins. These are essential for the rapid growth of new cancer cells. Some cancers even have two types of cells. One group depends on glucose for energy and produces lactate, a byproduct of glycolysis, while the other group uses the lactate from their neighbors as an energy source, tapping into the citric acid cycle to process it. This is an interesting way cancer cells adapt to their environment to maximize survival and growth. Moving on to tumor promoting inflammation, we know that most cancers are infiltrated by immune cells, which used to be thought of as the body's way of fighting the cancer. However, recent research shows that these immune cells actually help tumors grow and spread. The inflammation in tumors causes vasodilation, which is the widening of blood vessels. This allows more blood to flow into the tumor, but it also increases the permeability of the blood vessels, meaning that proteins and fluids leak out into the surrounding tissue. This leakage causes swelling. Inflammatory molecules called cytokines play a key role here. They help immune cells like neutrophils move from the bloodstream into the tissue, a process called extravasation. These cytokines also help the immune cells stick to the surface of blood vessels. They do this by promoting the expression of molecules like p-selectin on the inside of blood vessels, which allows the immune cells to roll along the vessel walls. Once they slow down enough, they attach firmly through special receptors and make their way into the tumor. This inflammatory response, which was once thought to be the body fighting cancer, actually ends up helping the tumor grow and spread. It's a key part of the tumor microenvironment and something researchers are now targeting to treat cancer more effectively. Cancer cells have the ability to escape the immune system, which normally acts as a barrier to prevent tumor formation and growth. This process of immune evasion is a key characteristic of cancer. Tumor cells continuously shed surface antigens into the bloodstream. These antigens usually trigger an immune response with cells like cytotoxic T cells, natural killer cells, and macrophages working to destroy the cancer cells. The immune system is supposed to act like a constant surveillance system, finding and eliminating cancer cells before they can grow into a tumor. However, cancer cells have developed clever ways to evade the immune system. For instance, cancer can cause problems in the development or function of SHA CD8 plus cytotoxic T lymphocytes, CD4 plus Th1 helper T cells, or natural killer cells, all of which are crucial for recognizing and killing cancer cells. This leads to a higher chance of cancer cells surviving and multiplying. Another strategy cancer cells use is to recruit regulatory T cells and myeloid-derived suppressor cells. These cells are immunosuppressive, meaning they prevent other immune cells, like cytotoxic T lymphocytes, from attacking the cancer cells. This helps the tumor hide from the immune system, allowing it to grow unchecked. The immune system can fail to recognize the cancer cells, or the cancer cells can reduce their vulnerability by escaping immune detection. In some cases, cancer cells might even cause immune dysfunction, weakening the immune response through inflammatory molecules. This immune escape is a significant reason why cancers continue to develop and progress despite the body's natural defense mechanisms. This ability of cancer cells to avoid immune destruction is one of the key features that make cancer so difficult to treat. Researchers are working on therapies to boost the immune system's ability to recognize and attack cancer cells, such as immunotherapy, which helps the immune system fight back more effectively. Cancer genetics involves understanding how mutations in genes cause cells to behave abnormally. There are two main types of genetic mutations related to cancer: germline mutations and somatic mutations. Germline mutations are inherited and present in a person's DNA from birth. These changes affect all of the body's cells, including sperm and egg cells, and can be passed down to the next generation. If someone inherits a mutation in a cancer causing gene, it can lead to hereditary cancer syndromes where family members are at higher risk of developing certain cancers. On the other hand, somatic mutations are acquired during a person's lifetime. These mutations occur in the DNA of individual cells, and they only affect the cell in which they happen and its descendants. These mutations are not passed on to offspring. Most cancers are caused by somatic mutations and are referred to as sporadic cancers, as they occur randomly and not because of inherited genetic mutations. Sometimes both types of mutations can affect the same genes. For example, a gene called APC is commonly mutated in sporadic colorectal cancer, cancer that happens without a family history. But the same gene is also mutated in familial adenomatous polyposis, an inherited condition that increases colorectal cancer risk. So even though the mutation is the same, how it occurs, inherited or acquired, can differ. Understanding both germline and somatic mutations is crucial. By studying the genetic changes in cancer, doctors can better understand how the cancer develops, classify different types of tumors, and create targeted therapies. For instance, HER2 is a gene that is often overexpressed in certain types of breast cancer. When this happens, the cancer cells are resistant to some treatments like taxane chemotherapy, but they are sensitive to a drug called trastuzumab, Herceptin, which specifically targets HER2. When it comes to how genes cause cancer, the process is related to several important biological changes. Cancer cells often grow uncontrollably, ignore signals to stop growing, and avoid cell death, apoptosis. They also can recruit blood vessels, angiogenesis, to supply the growing tumor with oxygen and nutrients, and they can invade surrounding tissues to spread, metastasize. At the genetic level, two major types of genes play a role: oncogenes and tumor suppressor genes. Oncogenes are mutated versions of normal genes called proto-oncogenes, which usually help cells grow. When these genes are mutated, they can promote uncontrolled cell growth. These mutations are a gain of function, meaning the gene becomes overly active, causing cells to proliferate abnormally. Since only one copy of the gene needs to be mutated to cause this effect, oncogenes behave dominantly at the cellular level. Tumor suppressor genes. Tumor suppressor genes normally work to prevent cell growth. These genes control processes like the cell cycle, DNA repair, apoptosis, programmed cell death, and telomerase regulation. When these genes are mutated, they lose their function, and this is called a loss of function mutation. In most cases, both copies of the tumor suppressor gene need to be mutated for cancer to develop. This is why these mutations are considered recessive at the cellular level. In sporadic cancers, both copies of the gene must be mutated in the same cell. However, in inherited cancers, a person gets one mutated copy of the gene from a parent, called the first hit, and then the second copy usually becomes mutated in a single cell during the person's life, the second hit. This process was first described as the two-hit hypothesis by Alfred Knudsen in 1971. A common confusion is that these cancers can follow dominant inheritance patterns, even though the mutations are recessive at the cellular level. The reason is that inheriting one defective gene significantly increases the likelihood of a second mutation happening in the person's life, which leads to cancer. This explains why inherited mutations in tumor suppressor genes sometimes behave dominantly. Multi-step carcinogenesis. Most cancers, around 90%, are not inherited but occur due to random acquired mutations. The process by which cancer develops involves multiple genetic changes over time. This process is known as multi-step carcinogenesis. A great example of this is colorectal cancer. First, a mutation in the APC gene causes the formation of benign polyps. Over time, these polyps can mutate further, eventually progressing into cancer if other genetic changes occur. Inherited cancer syndromes. Some cancers run in families. These are known as familial cancers, but hereditary cancers are those that follow a specific inheritance pattern. Family histories is very important in identifying people at risk, and those with suspected inherited cancer should be referred for genetic counseling and risk assessment. Autosomal dominant cancer syndromes. In some inherited cancer syndromes, the disease follows an autosomal dominant inheritance pattern. This means that each child has a 50% chance of inheriting the mutation. Whether the child develops cancer depends on how much the mutated gene disrupts normal cell function. If the gene's penetrance, how likely the mutation will cause disease, is high, then a large percentage of offspring will develop cancer. A well known example is Lynch syndrome, which is caused by mutations in DNA mismatch repair genes. People with Lynch syndrome have an increased risk of cancers like colorectal, gastric, endometrial, and ovarian cancers. Autosomal recessive cancer syndromes. In autosomal recessive cancer syndromes, both copies of the gene must be mutated for the disease to occur. If both parents are carriers, each child has a 10 to 25% chance of inheriting the disease. Detecting these conditions can be tricky, especially in families with few children. An example of an autosomal recessive cancer syndrome is ataxia telangiectasia, which is caused by mutations in the ATM gene. This gene is crucial for the p53 protein, which helps control cell growth. People with ataxia telangiectasia have a higher risk of cancers like leukemia and breast cancer. Communicating with cancer patients. Effective communication is crucial in all areas of medicine, but it becomes even more important when dealing with cancer patients. Cancer brings up strong emotions for both patients and doctors, which can sometimes make communication difficult. If communication isn't handled well, it can lead to misunderstandings, legal issues, and emotional stress for both sides. Healthcare professionals need to find their own communication style, but there are some general techniques that everyone can use. It's important to be authentic. Patients can easily tell if you're just acting or not genuinely engaged. It's also key to understand any barriers that might be preventing effective communication, whether it's fear, sadness, or confusion. Recognizing what might be hindering the conversation helps build a better relationship with the patient. The doctor patient relationship. Cancer care is often long term, and patients can feel very vulnerable, especially when emotions are running high. Doctors need to create an environment of trust where patients feel safe to express themselves. This starts with setting clear expectations and boundaries from the very first meeting. Patients should be involved in their own treatment decisions. The oncologist's job is to explain the diagnosis, what it means for the future, and what the treatment options are. This helps patients make informed choices about their treatment or, if necessary, end of life care. When faced with many treatment options, patients can feel overwhelmed, so it's essential to be clear and direct when explaining things. Breaking bad news. Breaking bad news. Breaking bad news is one of the most difficult parts of being a healthcare provider. Bad news refers to any information that negatively changes a patient's outlook on life, whether it's a cancer diagnosis, the progression of a disease, or a poor prognosis. What may seem like bad news to one person may be seen differently by another, which is why it's so important to approach each patient individually. Doctors need to recognize that the news may be devastating for the patient, even if it isn't something they personally feel is so terrible. Being aware of how patients may react can help doctors handle these situations with more empathy and care. Bad news, if delivered poorly, can stay with the patient for a long time, making the experience even more painful. Steps to breaking bad news. There are specific steps that can help make this difficult conversation easier for both the doctor and the patient. Preparing for the consultation. Make sure you have enough time and a quiet, private space to talk. Verify all the facts before you speak, and consider having a family member present if the patient wants support. Setting the scene. Begin by understanding what the patient already knows about their condition. Clarify the purpose of the conversation and ask how much information they want. Some patients may prefer not to know much, while others will want detailed answers. Warning shot. It can be helpful to give the patient a warning that bad news is coming. Simple statements like, "I'm sorry to say I have some difficult news for you," can help them mentally prepare. Chunking and checking. Don't overwhelm the patient with too much information at once. Give the news step by step and check regularly to make sure they understand. Encourage them to repeat what they've heard to ensure clarity and comprehension. Delivering bad news is never easy, but with the right approach, doctors can help patients understand their situation and make informed decisions about their care. It's important to remember that healthcare providers also need support after these challenging conversations. Talking with colleagues and reflecting on the experience can help manage any personal feelings and improve future communication. Encouraging patients to ask questions is an essential part of the consultation process. It's common for patients to feel overwhelmed, so many will want to write down questions ahead of time. As doctors, we should always be open to these questions and provide honest answers. If there's something we don't know, it's important to admit it and make an effort to find the information they need. Sometimes, it's helpful to anticipate what questions patients might have so we can address them up front, making the conversation smoother. Allowing the patient to express emotions. Cancer is an emotional journey for many patients, and it's important to allow them to express their feelings. The power of silence is often underestimated. Sometimes just giving the patient space to speak, or even sit in silence, can help them process their emotions. As healthcare professionals, we should be patient and compassionate and give them time to express themselves without rushing them. Understanding concerns and expectations. Every patient has different concerns and expectations. It's important to ask them what they're worried about, what they hope for from their treatment, and what their goals are. Sometimes family members or carers may also have concerns, and involving them in the conversation can be very helpful. Understanding these concerns helps in providing personalized care. Safety netting. After the consultation, it's helpful to offer a follow up appointment. This gives the patient a chance to ask more questions after they've had time to process the information you've provided. It's a safety net that ensures they don't feel abandoned or left with unanswered questions. Providing resources. Sometimes patients need more than just verbal information. Providing written leaflets or other resources can be really helpful. These resources can reinforce what was discussed and give patients something to refer back to when they need it. Documenting the consultation. It's essential to document the details of every consultation, including what was discussed, who was present, and any decisions made. This documentation is important not only for continuity of care, but also for legal reasons. It helps ensure that everything is recorded properly and can be referred to in future consultations. Dealing with emotional patients. Cancer diagnosis and treatment can trigger strong emotions, and patients may express them in different ways. As a doctor, it's crucial to stay calm, model emotional control, and offer empathy. Allowing time for pauses in the conversation gives patients the space to express their emotions. It's important to be empathetic rather than sympathetic. Empathy means understanding and sharing the patient's feelings, while sympathy may unintentionally make the patient feel pitied. Communicating with younger patients. Young patients, especially children and teenagers, may need a different approach to communication. It's important to include both the young patient and their parents or guardians in discussions. Sometimes it's helpful to speak with younger patients alone, as they may feel more comfortable opening up without others in the room. However, it's important not to patronize them or oversimplify information. While maturity doesn't always match age, it's crucial to ensure they understand the information. For younger patients, issues like hair loss from chemotherapy can be a big concern. A teenager, for example, may be more upset about losing their hair than about the cancer diagnosis itself. Being aware of these unique concerns can help you support the patient more effectively. When communicating with younger patients, it's essential to be yourself. Trying to act cool or like their peer may backfire, creating a barrier instead of fostering trust. Authenticity goes a long way in building respect and a strong doctor patient relationship. In summary, good communication with cancer patients involves listening, being honest, and creating a supportive environment. Tailoring your approach to each patient's needs, emotions, and age ensures that they feel heard, understood, and empowered to make informed decisions about their care. When cancer is just beginning, the number of malignant cells is small, and the patient may not show any symptoms. But as the tumor grows, signs start to appear. These can be due to the tumor pushing against nearby tissues or spreading locally. If cancer spreads, metastasizes to other parts of the body, new symptoms can develop. Sometimes tumors produce hormones or trigger immune responses that can also cause symptoms even if the cancer hasn't spread. General features to look for. One common sign of advanced cancer is unintentional weight loss, but this can also happen in other conditions like thyroid problems, chronic infections, or inflammatory diseases. If someone has unexplained weight loss, it's worth investigating cancer, but it's important to rule out other causes. Fever can also be a sign of cancer, especially in types like Hodgkin's lymphoma, leukemia, or kidney cancer, though infections can cause fever too. Another sign is pallor, or pale skin, which can happen from anemia, low blood count caused by cancer, especially cancers of the gastrointestinal tract or female reproductive organs. Weight gain might be seen in conditions like ascites, fluid buildup in the abdomen, or Cushing's syndrome, which can be caused by some cancers. Finger clubbing, where the tips of the fingers become rounded and swollen, is often associated with lung cancer, especially non small cell lung cancer. But it can also be caused by non cancerous conditions like hypertrophic osteoarthropathy, a type of joint disease. Local effects of cancer. Sometimes the first sign of cancer is a lump or mass that the patient or doctor notices. Cancers of the thyroid, breast, testis, and skin are often found this way. Palpable lymph nodes, which are swollen glands, can be another sign that cancer has spread. If there's a mass, it's essential to check the nearby lymph nodes for any signs of spread. For example, swollen lymph nodes in the neck or under the arms, axilla, could be linked to breast, lung, or esophageal cancer. Bleeding can happen when a cancer affects a mucosal surface, like the lining of the stomach, bowel, bladder, or lungs. This can lead to visible blood in urine or stool or hidden bleeding that causes anemia. It's a red flag that requires further investigation. Skin changes. Cancer can also affect the skin in various ways. Changes in a skin lesion's size, color, or shape should be checked out, as these could indicate skin cancer. Sometimes skin changes can also be a result of non metastatic effects of an underlying cancer. In summary, while some signs like unexplained weight loss or a lump might not always mean cancer, they should prompt investigation. Early detection through careful examination is crucial in diagnosing and managing cancer. Dysphagia, or difficulty swallowing, can be caused by cancers in the esophagus or stomach, and sometimes even lung cancer. The symptoms usually start off mild but get worse over time. What's important to note is that it's typically harder to swallow solids than liquids. If a patient experiences this, especially if it's progressively worsening, it could be a sign of a cancerous mass obstructing the esophagus. In the gastrointestinal tract, tumors can lead to a change in bowel habits. This could mean more diarrhea or constipation, which may be the first sign of a cancer like colorectal cancer. If a tumor blocks the bowel completely, it can cause nausea, vomiting, and abdominal pain, leading to bowel obstruction. Ovarian cancer, which often spreads to the abdomen, can cause similar symptoms due to pressure on the bowel. Lung cancer can cause airway obstruction, leading to symptoms like a persistent cough, recurrent chest infections, or even stridor, a high pitched wheezing sound when breathing. This could also be from compression by a tumor pressing on the airway. In some cases, an enlarged thyroid can cause similar symptoms due to compression. Another sign of cancer spread is early satiety, which is when a person feels full after eating only a small amount of food. This is often seen in liver metastasis, especially when cancer spreads from the lungs, stomach, or bowel. It can also happen with ascites, a condition where fluid builds up in the abdomen. Obstruction of conduits. Certain cancers can block pathways or conduits in the body. For example, a blockage in the bile ducts from pancreatic cancer or cholangiocarcinoma, bile duct cancer, can cause jaundice, a yellowing of the skin and eyes. Similarly, cancer in the cervix or other pelvic cancers can block the ureters, leading to hydronephrosis, swelling of the kidney due to urine buildup. Metastatic effects. When cancer spreads, it can cause various systemic symptoms. Jaundice, as mentioned earlier, can be caused by tumors blocking the biliary tract, as seen in cancers of the pancreas, stomach, or colon. This is different from jaundice caused by liver disease, which is called prehepatic jaundice. If a woman with advanced cancer has bone pain or a lung infection, focal consolidation in the chest, the doctor should examine the breasts, as the breast could be the primary cancer site that has spread. Metastasis to bone can also cause pain or fractures, especially from cancers like breast, lung, prostate, thyroid, or kidney cancer. Ascites, fluid buildup in the abdomen, and pleural effusions, fluid around the lungs, are common in cancers like ovarian, pancreatic, or stomach cancers. Organ enlargement like hepatomegaly, enlarged liver, or splenomegaly, enlarged spleen, can also be signs of metastatic cancer. Finally, cancer can lead to non metastatic symptoms like the specific changes caused by hormones or other substances produced by the tumor. These are less common but still important to recognize. So, when evaluating a cancer patient, remember that their symptoms may not just be from the tumor itself, but also from its spread or the body's response to it. Each of these signs should prompt further investigation to help pinpoint the cancer and understand how it's affecting the body. Cancer can sometimes cause symptoms that aren't directly related to the tumor itself, but are instead due to the body's response to the cancer. These are called paraneoplastic syndromes, and they can cause a wide range of effects. These symptoms can occur because the tumor produces abnormal substances, like hormones, depletes normal factors in the body, or triggers an immune response. One common paraneoplastic syndrome is ectopic hormone production, where tumors produce hormones that they normally wouldn't. For example, some cancers can produce hormones like insulin, ACTH, which normally comes from the pituitary gland, ADH, and even erythropoietin. When the cancer is treated and the tumor shrinks or is removed, the production of these hormones stops, and the abnormal metabolic effects usually resolve. A specific example of this is Cushing's syndrome, which can happen when a tumor produces excess ACTH, leading to high cortisol levels. This often causes symptoms like muscle weakness, high blood pressure, weight gain, and confusion. Cushing's syndrome can also be caused by pituitary adenomas or adrenal tumors, but in 20% of cases, it's due to ectopic ACTH production from small cell lung cancer or other neuroendocrine tumors. Diagnosis is confirmed by measuring cortisol levels and performing suppression tests. Another syndrome, carcinoid syndrome, happens when certain tumors, like carcinoid tumors, produce serotonin. Normally, serotonin is broken down in the liver, but if the tumor is outside the liver, like in the lungs or gastrointestinal tract, uh, the serotonin enters the bloodstream and causes symptoms like flushing, diarrhea, wheezing, and abdominal pain. Over time, this can lead to heart valve problems and other chronic issues. Diagnosis involves checking the levels of 5-AAA, a breakdown product of serotonin. Neurological manifestations can also occur in some cancer patients due to an immune response against the tumor. In these cases, the body creates antibodies that mistakenly attack normal nerve or muscle tissue. These manifestations can be rare but are well recognized. For example, peripheral neuropathy, nerve damage causing weakness and numbness, can occur due to the body's immune response. Encephalomyelitis, inflammation of the brain and spinal cord, may also develop, leading to a range of neurological symptoms like confusion or difficulty walking. A more specific example is cerebellar degeneration, where the part of the brain responsible for coordination is damaged, leading to symptoms like unsteady walking, nystagmus, eye shaking, and slurred speech. Lambert-Eaton myasthenic syndrome, LMS, is another condition that occurs in some cancer patients. In lemons, antibodies attack calcium channels in nerve endings, leading to muscle weakness. Interestingly, the weakness often improves with exercise. If a patient suddenly develops symptoms like ptosis, drooping eyelids, or muscle weakness that gets better with exercise, doctors should consider the possibility of an underlying cancer. Even after cancer treatment is successful, paraneoplastic effects can persist. This happens because while the tumor may be gone, the antibodies or immune responses triggered by the tumor might continue, causing ongoing symptoms. So, when a patient presents with unexplained neurological or metabolic symptoms, it's important to think about paraneoplastic syndromes, especially if the cancer is not yet diagnosed. Skin changes are often one of the first signs that something might be wrong with a patient, and certain skin conditions can be linked to underlying cancers. For example, pruritus, itching, is sometimes seen in cancers like lymphoma, leukemia, or even brain tumors. Acanthosis nigricans, which causes dark, thickened skin in body folds like the armpits, is often associated with gastric cancer and can appear years before the cancer is diagnosed. Other skin conditions like pemphigus, blistering skin, are seen in cancers like lymphoma, Kaposi's sarcoma, or thymic tumors. Vitiligo, the loss of skin pigment, is frequently linked to melanoma, possibly due to the immune system attacking the pigment producing cells. Another important cutaneous manifestation is dermatomyositis, a condition causing muscle weakness and a distinctive rash. About 40% of cases are associated with cancers, particularly those of the stomach, lungs, and ovaries. It's important to investigate further when a patient presents with this rash. Similarly, erythema gyratorum, which looks like wood grain, is strongly linked to lung, breast, and gastrointestinal cancers. The skin can also show signs of ectopic hormone production. For instance, Cushing's syndrome, which causes changes like skin thinning and bruising, might be seen in patients with cancers producing excessive hormones. Moving to hematological blood changes, cancer can affect blood counts in various ways. Anemia, low red blood cells, is common, especially in cancers like those of the gastrointestinal tract, where chronic blood loss can lead to iron deficiency. Leukocytosis, high white blood cell count, often occurs in cancers like lymphoma, lung, and gastric cancers due to cytokine release. On the other hand, eosinophilia, high eosinophils, a type of white blood cell, is seen in cancers like Hodgkin's lymphoma, a dangerous blood clotting condition called Trousseau's syndrome, which causes blood clots, is often found in cancers like pancreatic and ovarian cancer. When it comes to gastrointestinal GI issues, weight loss and anorexia, loss of appetite, are very common in cancer patients, especially in those with cancer cachexia, cassis. This condition is caused by inflammation from the tumor itself, which speeds up metabolism. Over 50% of patients with solid tumors experience significant weight loss, and if it's more than 10% of their body weight, it usually signals a poor prognosis. Treatment focuses on nutritional support, though steroids can help stimulate appetite in the short term. Some cancers affecting the bowel can lead to issues like protein losing enteropathy, where proteins are lost through the gut, leading to low protein levels and conditions like ascites, fluid in the abdomen, or peripheral edema, swelling in the legs. Renal issues can also arise in cancer patients, particularly due to immune complex deposition, which can affect the kidneys and cause conditions like nephrotic syndrome. Around 10% of people with nephrotic syndrome have an underlying cancer, with stomach, lung, and liver cancers being the most common culprits. Lastly, perineoplastic syndromes can include unusual signs like hypertrophic osteoarthropathy, HOA, which causes clubbing of the fingers and pain in the joints. It's commonly associated with lung cancer, especially squamous cell carcinoma. Fever is another nonspecific symptom seen in many cancers caused by the body's immune response to the tumor. About 30% of cancer patients experience fever, and it's important to rule out infections, like especially in those undergoing chemotherapy. In some cases, specific fever patterns like Pell-Epstein fever, fever that comes and goes in a cyclical pattern, can point to specific cancers like Hodgkin's disease. These are just a few examples of how cancer can affect the body in ways that may not immediately point to the presence of a tumor, but understanding these patterns can help doctors diagnose and treat cancer earlier. Hypercalcemia is a common problem in cancer patients, affecting up to 40% of them. It is a serious condition that often signals a poor prognosis. It happens most frequently in cancers like multiple myeloma, breast, lung, kidney, head and neck cancers, and lymphoma. The main cause of hypercalcemia in cancer is the production of a substance called parathyroid hormone related peptide, PTHRP, by the tumor. PTHRP acts on the bone, kidneys, and gastrointestinal system to increase calcium levels in the blood. In most cases, 80%, this is the main cause. The remaining 20% are due to bone destruction, where cancer cells in the bone marrow cause the bones to release calcium into the blood. The symptoms of hypercalcemia are often vague and can resemble the symptoms of advanced cancer. They include fatigue, nausea, constipation, and confusion. To diagnose it, doctors use a blood test to measure calcium levels, but they also need to adjust for albumin levels in the blood because albumin binds to calcium, and this can affect the readings. Treatment for hypercalcemia usually starts with rehydration, meaning the patient is given large amounts of intravenous fluids. After that, a medication called Bisphosphonates, like pamidronate, is used to help lower the calcium levels. In about 80% of patients, calcium levels return to normal within 3 days with this treatment. For the remaining 20%, doctors might use other medications like octreotide, a type of somatostatin analog, calcitonin, or mithramycin. It's also important to stop any medications that might increase calcium levels, such as thiazide diuretics. Another complication in cancer patients is the syndrome of inappropriate antidiuresis, SIA, which causes low sodium levels, hyponatremia. In cancer, this is often due to ectopic antidiuretic hormone, ADH, secretion, meaning the tumor is producing a hormone that causes the kidneys to hold onto too much water, diluting the sodium in the blood. This can lead to symptoms like confusion, stupor, and even seizures if the sodium levels fall too low. The diagnosis of SIAD is made based on blood and urine tests. The essential criteria include low blood sodium, low blood osmolality, a measure of the concentration of particles in the blood, and high urine osmolality, indicating the kidneys are concentrating urine. Treatment typically involves fluid restriction to prevent further dilution of sodium. D-meclocycline, a medication that helps reduce the effect of ADH, is also used. In cases of severe symptoms, hypertonic saline can be given to quickly raise sodium levels. The treatment of SIAD also involves managing the underlying cancer, as this can help reduce the secretion of ectopic ADH and improve the patient's condition. Hypomagnesemia is a condition where the magnesium levels in the blood are too low. It typically occurs due to loss of magnesium through the gastrointestinal tract, like from diarrhea, or renal tract through the kidneys. In fact, many times, hypomagnesemia is seen alongside hypokalemia, low potassium levels, in up to 60% of cases. This happens because both magnesium and potassium can be lost together, especially in conditions like diarrhea. When magnesium levels are extremely low, less than 0.5 millimoles per liter, it can lead to hypocalcemia, low calcium levels, because the body's production of parathyroid hormone increases when magnesium is low. Symptoms of hypomagnesemia can affect both the nervous system and muscles, leading to irritability, confusion, psychosis, seizures, or even coma. Cardiac arrhythmias, irregular heart rhythms, are also common, especially if the person already has heart disease. Along with low magnesium, patients might also experience low potassium and calcium levels, which can make the symptoms worse. Blood tests, including calcium, creatinine, and ionized magnesium, the active form, are important for diagnosing this condition. When treating hypomagnesemia, it's important to correct the deficiency slowly. Magnesium correction should be done gradually, usually by giving intravenous magnesium, 50 millimole over 8 to 24 hours, to prevent sudden changes in magnesium levels, which could worsen kidney function. Once the patient is stable, oral magnesium supplements are often used for longer-term management. Tumor lysis syndrome, TLS, happens when a large number of cancer cells are destroyed quickly, typically due to chemotherapy. This is more common in cancers like lymphoma, leukemia, and germ cell tumors. The rapid breakdown of cancer cells releases large amounts of potassium, phosphate, nucleic acids, and purines into the bloodstream. This leads to high levels of potassium, hyperkalemia, phosphate, hyperphosphatemia, and uric acid hyperuricemia, as well as hypocalcemia, low calcium levels. The biggest concerns with TLS are kidney problems caused by uric acid crystals forming in the kidneys, leading to acute kidney failure. Patients with TLS can develop symptoms like fatigue, nausea, vomiting, irregular heart rhythms, seizures, or even sudden death. To manage TLS, hydration is crucial, as it helps to dilute the electrolytes in the blood and improve kidney function. Monitoring of serum biochemistry, blood tests, is necessary for the first 48 to 72 hours after treatment. In high-risk patients, hydration should begin 24 hours before treatment. Allopurinol, or rasburicase, a drug that helps break down uric acid, can be used to manage high uric acid levels. In severe cases where other treatments don't work, hemodialysis may be needed to prevent kidney damage from worsening. Neutropenic sepsis is a serious condition that happens when a person with neutropenia, a very low neutrophil count, develops an infection. Neutropenia is defined as a neutrophil count of less than 0.5, 10 milder, which is commonly seen after chemotherapy treatments. If the person develops a fever above 38 degrees Celsius, it's called febrile neutropenia, and this is an emergency. The infection can worsen very quickly, so recognizing and treating it early is crucial. Chemotherapy can lower the number of neutrophils in the blood, making it harder for the body to fight infections. Radiotherapy can also cause neutropenia if large areas of bone marrow are affected, or if the marrow is infiltrated by cancer cells. When a patient with neutropenia develops a fever, the first step is to rule out infection. This means taking blood cultures from both peripheral and central lines, collecting a urine sample, MSU, getting a chest x ray, and swabbing areas like the throat or central line site for culture. These tests help identify where the infection might be coming from, but if there's no clear source, it's important to start antibiotics right away based on local guidelines and the patterns of antibiotic resistance seen in that hospital. The initial antibiotic treatment often includes drugs like tazocin or meropenem and sometimes gentamicin. If there's concern about anaerobic infections, metronidazole might be added, or if a gram-positive infection is suspected, antibiotics like flucloxacillin, vancomycin, or teicoplanin might be given. If the patient doesn't improve after 36 to 48 hours, it's time to review the antibiotics and consider adding antifungal treatment. Granulocyte colony stimulating factor, GCSF, may be used in some patients to help boost their neutrophil count, but it's not routinely used for all cases of neutropenia. Superior vena cava obstruction, SVC obstruction, happens when a tumor blocks the superior vena cava, the large vein that carries blood from the upper body back to the heart. This is most commonly seen in lung cancers, especially small cell lung cancer, or SCLC, lymphoma, germ cell tumors, and sometimes in metastatic tumors. It can also occur if a blood clot forms, especially in patients with central intravenous lines. The symptoms of SVC obstruction can develop slowly over weeks or months. These include headaches, dusky skin color, especially over the chest, arms, and face, swelling of the arms and face, and distended veins in the neck and arms. If the obstruction gets worse quickly, patients may develop more severe symptoms like difficulty breathing, stridor, a high-pitched wheezing sound, and changes in mental status. To confirm the diagnosis, CT imaging of the chest with contrast is used. In the meantime, the patient should be sat up to help with breathing, and oxygen should be given if needed. Steroids, like dexamethasone, can help reduce swelling around the tumor and make the patient more comfortable. In some cases, a tissue biopsy is needed to identify the type of tumor. Some cancers, like lymphoma or germ cell tumors, respond better to chemotherapy than to radiotherapy. For most patients with SVC obstruction, stenting the superior vena cava, followed by mediastinal radiotherapy, is the most effective treatment and can relieve symptoms in up to 90% of patients within 2 weeks. Spinal cord compression, SCC, is a serious condition that occurs in about 5% of cancer patients, but can be the first sign of cancer in up to 20% of patients. This means doctors need to be especially aware and look out for symptoms, even in patients who don't yet have a cancer diagnosis. Compression happens when a tumor presses on the spinal cord, and it can be caused by a vertebral tumor, a collapsed vertebra due to tumor destruction, or even a tumor growing inside the spinal cord itself. Tumors that spread to the spine, such as those from breast, prostate, and lung cancers, are common causes. In fact, it's more common in cancers that affect the bones or spread to them, like multiple myeloma. The compression usually happens in the thoracic spine, 70% of cases, followed by the lumbar spine, 20%, and the cervical spine, 10%. The early sign of spinal cord compression is back pain, especially when coughing or lying flat. As the compression progresses, symptoms will spread. You might see sensory changes, numbness or tingling, below the level of the compression, followed by motor weakness, difficulty moving limbs, and finally, issues with bowel or bladder control. Sometimes compression happens in the lower spine, the cauda equina or conus medullaris, which can cause more severe symptoms like loss of sensation and motor function in the lower body. If there are signs of bilateral upper motor neuron problems, like weakness or spasticity in both limbs, think of spinal cord compression until proven otherwise. Spinal cord compression is considered a medical emergency because, if untreated, it can lead to permanent damage. The first step in treatment is high dose steroids, usually dexamethasone, to reduce swelling and inflammation around the spinal cord. Next, an MRI scan should be done urgently to locate the exact level of compression. While x rays might show vertebral collapse, they don't always pick up all cases of spinal cord compression. Once the compression is confirmed, the treatment depends on the patient's situation. If the cancer is limited to the spine and there is only one spot of compression, surgery to decompress the cord can be done. This is especially helpful if the cancer is newly diagnosed and a biopsy can be taken during surgery. However, in cases where surgery isn't possible, radiotherapy is usually the next step. The symptoms might worsen temporarily before improving due to the swelling caused by radiation. The outcome largely depends on how much neurological damage there is before treatment starts. If the patient is still able to walk when treated, there's a good chance they will remain ambulatory about 80% of the time. But if the spinal cord compression is untreated for too long, paralysis and loss of bowel or bladder control are possible. And unfortunately, once this function is lost, it often can't be restored. In general, about 30% of patients will survive for at least a year after treatment. The key to success is early detection and treatment. If a patient presents with new or worsening back pain, motor dysfunction, or sensory changes, it's important to consider spinal cord compression and act quickly to prevent permanent damage. Metastatic spread is a critical feature of malignant cancers, where the cancer cells travel to other parts of the body. This spread can occur through two main routes: lymphatic spread, which targets nearby lymph nodes, and hematogenous spread, which moves cancer cells through the bloodstream to distant organs. Metastasis is the leading cause of death and illness in cancer patients. While most treatments focus on palliative care, meaning they aim to improve quality of life rather than cure the disease, treating a single metastasis in certain cases can sometimes lead to a cure. Brain metastases. Brain metastases happen in about 10 to 30% of adults with cancer and can cause significant symptoms. Common cancers that spread to the brain include lung, breast, melanoma, and colon cancers. These metastases can involve the brain tissue itself or structures like cranial nerves and blood vessels. Without treatment, the average survival time is just 1 month. But with steroids, it may increase to 2 to 3 months, and with whole brain radiotherapy, it can extend to 3 to 6 months. Diagnosis is typically made through CT scans or MRI with contrast, and in some cases, carcinomatous meningitis, spread to the brain's lining, can be confirmed by testing the CSF for cancer cells. Treatment often includes steroids to reduce swelling, anticonvulsants for seizures, and sometimes radiotherapy or chemotherapy. Surgery can be an option for single brain metastases and can offer a potential cure, especially when combined with stereotactic radiotherapy. Stash lung metastases. Lung metastases. Lung metastases are commonly seen in cancers of the lung, breast, colon, thyroid, sarcomas, renal cancers, and cancers from the head and neck. A single lung metastasis may be difficult to differentiate from a primary lung cancer, but multiple lung nodules are more likely to be metastases. Treatment options depend on the extent of the disease. For a solitary lesion, surgery may be an option, while other systemic treatments like chemotherapy, radiotherapy, or endocrine therapy may be used depending on the type of cancer. Liver metastases. The liver is a common site for metastatic spread, and liver metastases can be the main problem for patients with cancers like colorectal cancer, breast cancer, and others. These metastases are often found when liver function tests are abnormal or on imaging studies. In colorectal cancer, surgically removing a single liver metastasis can significantly improve long-term survival from just 3% to 30 to 40%. Other treatments include chemoembolization or radiofrequency ablation for small, limited metastases. If these treatments aren't an option, chemotherapy may help manage symptoms. Bone metastases. Bone metastases are the third most common site for cancer spread after the lungs and liver. They can occur in cancers that don't traditionally spread to bone, like breast and prostate cancers, especially as patients live longer due to advancements in treatment. The detection of bone metastases can be tricky. Bone scans are sensitive but may miss cases in multiple myeloma, so x rays are often preferred. If there is a single bone lesion, a biopsy is crucial because it can look similar to a primary bone tumor. Threat of treatment. The goal of treatment is to control pain, stabilize the skeleton, and manage any complications like fractures. Surgical intervention may be needed in cases of skeletal instability, like fractures or impending fractures. Bisphosphonates like pamidronate are commonly used to reduce pain and prevent complications like fractures or high calcium levels in the blood. In cancers like breast and prostate, hormonal therapy can be helpful, while radiotherapy or chemotherapy may also play a role depending on the cancer type. Metastatic disease presents many challenges in treatment and management, but early detection and tailored treatments can improve survival rates and quality of life for many patients. Malignant pleural effusion is a common complication in cancer patients, with about 40% of all pleural effusions being caused by malignancy. The most frequent cancers responsible are lung cancer, breast cancer, lymphoma, and leukemia. The presence of a pleural effusion typically indicates that the cancer is at an advanced, often incurable stage. The first step in diagnosing malignant pleural effusion is usually a pleural aspirate, a sample of the fluid from the pleural space. This can reveal the presence of malignant cells. The fluid is typically blood stained and is considered an exudate, meaning the fluid has higher levels of protein and LDH compared to normal pleural fluid. Specifically, the fluid serum LDH ratio is greater than 0.6, and the fluid serum protein ratio is greater than 0.5. When treating malignant pleural effusion, the goal is usually to relieve symptoms and provide palliative care tailored to the patient's condition and prognosis. For patients with a limited life expectancy, simple aspiration of the fluid may be enough. However, in patients where the pleural effusion is the first sign of cancer, like breast cancer, small cell lung cancer, or lymphoma, more aggressive treatment is needed. Uh, this may include chemotherapy to treat the cancer that has spread to the pleura. For patients with recurrent pleural effusion, more invasive treatments like pleurodesis, a procedure that causes the pleural layers to stick together, preventing fluid buildup, pleurectomy, surgical removal of the pleura, or pleuroperitoneal shunt, a tube to drain fluid into the peritoneal cavity, might be considered. Pleurodesis is generally performed after the fluid recurs following an initial drainage. Malignant ascites is the buildup of fluid in the abdomen, peritoneal cavity, and is commonly caused by cancer spreading to the peritoneum, the lining of the abdomen. It can be a sign of advanced disease and has prognostic significance. Diagnosis is usually made based on clinical examination, but imaging techniques like ultrasound, MRI, or CT can be helpful for draining the fluid, especially when it's pocketed. Non-cancerous causes of ascites include heart failure, liver cirrhosis, kidney failure, and infections. Around 10% of patients with ascites have an underlying malignancy, but in those with advanced cancer, ascites is usually cancer-related. Cytology, examining the fluid for cancer cells, is needed to confirm malignancy, especially for staging or surgical planning. In ovarian cancer, for example, patients with malignant ascites tend to have a better prognosis, so it's crucial to investigate the cause thoroughly. Paracentesis, draining the fluid, is the most common treatment for malignant ascites. For recurrent cases, indwelling catheters like the Plurk's catheter may be used. Diuretics, medications that help the body remove excess fluid, are generally ineffective for malignant ascites because the issue isn't caused by fluid retention. Other treatments, like peritoneovenous shunting, a device that drains fluid into the veins, or surgical debulking, removal of tumors, may help but have uncertain long-term benefits. In cases of skin metastases, local radiotherapy can help with symptom control, though it's primarily for cosmetic and comfort reasons. Heart metastasis is rare but can occur, particularly with breast, lung, and ovarian cancer. When the pericardium, the sac around the heart, is involved, treatment usually focuses on draining the fluid and managing the underlying cancer. Serum proteins and tumor markers are proteins secreted by cancer cells that can be detected in the blood. These markers are important because they help in diagnosing cancer, monitoring treatment, and sometimes even in screening for certain cancers. They can also be used to predict how a patient will do, prognosis, and to check for relapses or the spread of cancer. For a tumor marker to be clinically useful, it should meet certain criteria. It should be easy and quick to test. It should be cheap. It should have high sensitivity, meaning it can correctly identify people with the disease, and high specificity, meaning it can correctly identify those without the disease. It should also provide a high predictive value in both positive and negative test results. Sensitivity refers to the ability of a test to correctly identify people who have the disease, while specificity refers to the test's ability to correctly identify those who don't have the disease. The positive predictive value is how likely a positive result really indicates the presence of the disease, and the false positive rate is how often the test gives a positive result when the person doesn't actually have the disease. Let's look at some common tumor markers. One, human chorionic gonadotrophin, HCG, is a glycoprotein produced during pregnancy by the placenta. It's used not only for pregnancy testing, but also for diagnosing and monitoring certain cancers like gestational trophoblastic disease and germ cell tumors, tumors from cells that can develop into any type of tissue. It's a very reliable marker for testicular and placental cancers with 100% sensitivity for choriocarcinomas and hydatidiform moles, and lower sensitivity for other types of germ cell tumors. 2. Alpha fetoprotein, AFP, is produced by the liver, yolk sac, and intestines in a developing fetus. In adults, elevated levels can indicate cancers like hepatocellular carcinoma, liver cancer, or germ cell tumors of the testes and ovaries. It can also be elevated in some non-cancerous liver diseases or even in patients receiving chemotherapy. 3. Placental alkaline phosphatase is another marker that can be elevated in certain cancers, especially testicular seminomas and ovarian dysgerminomas, a type of ovarian cancer. It's also important to note that slightly elevated levels can be found in smokers. 4. CA19-9 is a mucin, a type of protein found in the cells of the stomach, intestine, and pancreas. It's mainly used to monitor treatment in gastric and pancreatic cancers. While it can indicate the presence of metastatic disease when levels are extremely high, over 10,000, it's not good for screening. Levels can also rise in cases of cholestasis, bile flow problems, and in some mucinous ovarian tumors. Over 5. Inhibin is a protein produced by the ovaries, particularly by granulosa cells. It is used to monitor granulosa cell tumors of the ovary, which are rare tumors that respond well to treatment. 6. Carcinoembryonic antigen, CEA, is a protein found in the gastrointestinal tract, and its levels can be elevated in several cancers, including those of the colon, pancreas, ovary, stomach, and others. However, it can also be elevated in non-cancer conditions like inflammatory bowel disease, trauma, and even smoking. Despite this, it's useful for monitoring cancer treatment or recurrence, particularly in cancers of the gastrointestinal tract. Tumor markers are helpful tools, but they are rarely used in isolation. They are most useful when combined with other diagnostic tests, imaging, and clinical evaluations. They can provide important information about disease progression, response to treatment, and help predict future outcomes. CA15-3 is a protein often used to monitor breast cancer. It's not useful for screening early stages of breast cancer as it has low sensitivity at that stage. However, CA15-3 levels can be elevated in women with breast cancer, especially in those with metastatic disease, when the cancer has spread to other parts of the body. It's found to be elevated in about 12.5% of women with benign breast conditions, 11% in women with operable breast cancer, and 64% in those with metastatic disease. What's really useful about CA15-3 is that it can help detect cancer relapse before clinical signs appear, sometimes 2 to 9 months earlier. It's particularly helpful for monitoring patients after treatment, especially if the levels are rising, as it suggests the cancer may be returning. CA125 is another marker, often used for ovarian cancer. It's found in tissues like the fallopian tubes, endometrium, and peritoneum. It's elevated in more than 80% of women with non-mucinous epithelial ovarian tumors, but it is especially useful for advanced stage ovarian cancer, stage 3 or 4. However, it is less reliable for early stage ovarian cancer, being elevated in only about 50% of stage 1 cases. Although CA125 is not good for screening, it can be very useful in monitoring treatment and detecting relapse in ovarian cancer patients. For example, if CA125 levels drop significantly after chemotherapy, that's a good sign. But if the levels remain high or rise, it might indicate that the cancer is not responding well to treatment. SC squamous cell carcinoma antigen is another tumor marker that's helpful for monitoring squamous cell carcinomas, especially in cervical and head and neck cancers. It's found in about 70 to 85% of cervical squamous cell cancers and 60% of head and neck squamous carcinomas. It can also be elevated in non-small cell lung cancer NSCLC, particularly in squamous NSCLC, so it can help track the progression of these cancers. PSA, prostate specific antigen, is a well known marker for prostate cancer. PSA is produced by the prostate and helps make semen more fluid, which aids sperm mobility. Elevated levels of PSA are often found in prostate cancer, but it's not perfect for early detection. About 50% of men with microscopic prostate cancer will have elevated PSA levels, and 77% of those with macroscopic larger disease will have elevated levels. It's also seen in men with benign prostatic hypertrophy, BPH, which is a non-cancerous enlargement of the prostate. PSA testing combined with a digital rectal exam is often used in the USA for screening, but this isn't recommended in the UK as there's no solid evidence showing it improves survival outcomes. Finally, hormones like calcitonin and catecholamine metabolites can also be used to monitor certain cancers. Calcitonin is useful for detecting medullary thyroid cancer, while catecholamine metabolites, such as vanillyl-mandelic acid and homovanillic acid, are used to monitor neuroblastoma, a cancer of nerve tissue. These hormone markers help track the presence and progression of tumors in the endocrine system. In summary, these markers are valuable for monitoring cancer, especially after treatment. They help doctors decide how well the treatment is working and whether the cancer has returned. However, they are not perfect and are usually used in combination with other tests and clinical evaluations to make the best decisions for the patient. Cancer screening involves testing large groups of people to find cancer before symptoms appear. The goal is to detect cancer early so it can be treated when it's easier to manage. However, for screening to work, it needs to meet certain standards, such as being easy to perform, affordable, and able to accurately detect cancer or precancerous conditions. For a screening test to be effective, it should have high sensitivity, meaning it can find most people who actually have cancer, and high specificity, meaning it can correctly identify people who don't have cancer. If a test fails to find all those with cancer, low sensitivity, or wrongly suggests cancer in healthy people, low specificity, the screening won't be useful. Successful screening programs also need to focus on a specific target population, people who are at higher risk. For example, women with BRCA1 gene mutations are at higher risk for breast and ovarian cancer, so they might be screened more often or offered preventive surgeries like mastectomy, removal of breasts, or oophorectomy, removal of ovaries. The idea is to catch the cancer early or prevent it altogether. However, early detection is only valuable if it leads to effective treatment that can actually improve survival. If the cancer is detected late, even early treatment might not make much of a difference in extending life. There are two important biases to be aware of in cancer screening. One, lead time bias. This happens when screening detects cancer earlier, but the earlier detection doesn't actually make the patient live longer. It just makes it look like the person has lived longer because the cancer was found earlier, even though the treatment didn't change the outcome. Two, length time bias. This occurs when slower growing cancers, which are less aggressive, are more likely to be detected by screening. These cancers would have had a better outcome anyway, so it may appear that screening improved survival, but it's just because the cancers detected were less aggressive. Breast cancer screening with mammograms is one of the most successful screening programs. Mammograms can find small cancers, less than 2 centimeters, that haven't spread to the lymph nodes. Studies have shown that mammography reduces breast cancer deaths by about 25% in women aged 50 to 69 years. The most benefit is seen when screening is done every 2 to 3 years. Screening younger women hasn't shown a clear benefit yet, and women over 70 haven't been studied enough to know if they benefit from screening. For colorectal cancer, studies have shown that screening with tests like fecal occult blood tests and sigmoidoscopy can reduce deaths from colon cancer. Screening is especially important for people over 50 and those with a family history of certain conditions, like familial adenomatous polyposis or hereditary non-polyposis colorectal cancer (HNPCC), should have regular colonoscopies to catch problems early. In summary, while screening can help find cancer early and save lives, it needs to be carefully targeted, well executed, and linked to treatments that actually improve outcomes. Understanding these biases and the limitations of screening tests helps ensure that the benefits are real and meaningful. Gastric cancer is a type of cancer that can be treated successfully if detected early. In Japan, where the rate of gastric cancer is high, endoscopic screening has proven effective. By detecting cancer at an early stage, many cases are treated successfully with surgery, leading to higher survival rates. When it comes to prostate cancer, screening is more controversial. Studies with PSA, prostate specific antigen, tests, and digital rectal exams showed that 3.5% of men had prostate cancer, most of which were localized and treatable. However, no large scale randomized trials have shown a clear link between screening and increased survival. One model suggests that while an ideal screening program could prevent a few deaths and extend life by a few months on average, it doesn't dramatically improve survival for most men. This is because prostate cancer often grows slowly, and many men may not live long enough for the cancer to affect them. Cervical cancer screening has been very successful in detecting early signs of cancer, especially with methods like the Papanicolou PAP smear. This test detects cervical intraepithelial neoplasia, CIN, a precancerous condition. The UK has a screening program that tests women every 3 years from age 25 to 49 and every 5 years for women aged 50 to 64. The program has significantly reduced the number of cases of squamous cervical cancer. Um, However, it's not as effective at detecting adenocarcinoma, a different type of cervical cancer. Ovarian cancer screening using CA-125 blood tests or ultrasound is still being studied. Although it can catch cancers early, there's no clear evidence yet that it improves survival. This is true even for women with BRCA1 or BRCA2 gene mutations who are at higher risk for ovarian cancer. For lung cancer, screening with chest x-rays and sputum cytology examining mucus for cancer cells hasn't been proven to reduce deaths, even for high-risk groups like smokers. Newer methods like low-dose CT scans are still being tested to see if they can detect lung cancer earlier and reduce mortality. Looking to the future, better screening tests and more effective treatments are needed for cancer to be detected earlier and treated more effectively. We're also learning more about genetic predisposition to cancer with advances in molecular medicine. Some patients with inherited genetic mutations may be at higher risk and could benefit from earlier screening or preventative treatments. However, only about 10% of cancers are caused by genetic mutations, and more research is needed to find effective screening for people without these genetic risks. In summary, while cancer screening can help detect cancers early and improve survival, it's not perfect. Screening programs are still being improved, and some cancers, especially those with no early symptoms, are harder to detect. Imaging plays a crucial role in cancer care, helping doctors from diagnosis all the way through to monitoring treatment and detecting recurrence. It helps determine how far the cancer has spread, assess how the cancer is responding to treatment, and guide certain procedures. However, it's important to balance the benefits of imaging with the potential risks, such as exposure to radiation, which is a concern with some imaging methods. Plain film imaging, like X rays, is commonly used for checking the skeleton, especially to look for bone changes caused by metastasis, such as areas where the bone is becoming more solid, sclerotic, or breaking down, lytic. A simple chest X ray is often the first step in screening for lung metastasis or infection. It's also used in breast cancer screening through mammography, which can detect lumps and small calcium deposits, microcalcifications. Mammography is the only imaging method proven to be effective in breast cancer screening, and if any abnormal results are found, further testing like ultrasound or biopsy will be done. Ultrasound is another valuable tool, especially because it can be done at the bedside and doesn't require radiation. It uses high frequency sound waves to create images of tissues, and it's especially useful for assessing areas like the liver, thyroid, kidneys, and testes. For example, in the case of testicular masses, ultrasound can help distinguish between a benign cyst and a more serious solid mass, such as cancer. It's also used in combination with endoscopy to assess tumors in places like the esophagus or lungs. CT, computed tomography, is one of the most commonly used imaging techniques in cancer care. It provides detailed images that help doctors determine how far the cancer has spread locally and to other parts of the body. It's particularly useful for assessing lymph node involvement and distant metastasis. However, there can be limitations, like the possibility of false positives or false negatives, especially when detecting small lymph nodes or areas like the bowel, which might appear suspicious even if there's no cancer. CT is particularly good at detecting pulmonary metastasis, cancer spread to the lungs. MRI, magnetic resonance imaging, offers detailed information not just about the structure of tissues, but also about their function and even their molecular characteristics. This allows doctors to see tumors with great precision, especially soft tissues. MRI can help classify tumors, locate them accurately, and provide additional information about how the tumor is affecting the surrounding environment. This is important for staging cancers and planning treatments. In summary, while all these imaging techniques have their strengths and weaknesses, they work together to provide comprehensive information that guides cancer diagnosis, treatment planning, and monitoring. Each type of imaging has its specific use, and the choice of which to use depends on the type of cancer, its location, and what information is needed. MRI is the go-to imaging technique for evaluating tumors in the brain, spine, and muscles. It's also very useful for checking vascular issues, pelvic problems, and liver-related conditions. In the case of liver and bile ducts, magnetic resonance cholangiopancreatography, MRCP, is becoming a popular choice, replacing the older method of endoscopic retrograde cholangiopancreatography, ERCP. MRI can also be used to detect breast cancer, especially in women with dense breast tissue, where other methods might miss the cancer. However, there's some caution around using MRI contrast, gadolinium, in patients with kidney problems, as it can sometimes cause a rare but serious condition called nephrogenic systemic fibrosis. MRI has improved a lot with faster technology. It can now measure blood flow in tissues and track the movement of gadolinium, a contrast agent, with high precision. This allows doctors to look at things like brain blood volume, blood brain barrier leakage, and even how much necrosis dead tissue is in a tumor. It provides incredibly detailed pictures, helping in better diagnosis and treatment planning. Radioisotope imaging, on the other hand, isn't as specific or sensitive as other methods, but it delivers a smaller dose of radiation. For example, a bone scan can detect areas of increased metabolic activity in the skeleton, such as in metastatic cancer, but it can also pick up infections or fractures. So, while it's a sensitive test for bone metastasis, it can give false positives, meaning a finding might not always indicate cancer. These results often need to be confirmed with other imaging, like X rays. Radioisotopes are also used in detecting sentinel lymph nodes during surgery. A radioactive substance is injected into the tumors, and the first lymph node that picks it up, the sentinel node, is removed and tested for cancer. This technique helps doctors avoid the need for extensive lymph node removal if the sentinel node is cancer-free, making it a less invasive way to check for spread with high accuracy, 95%. Positron emission tomography imaging is fantastic for staging cancer and monitoring how well a tumor is responding to treatment. PET scans detect how much glucose the cells are using, which is usually higher in cancer cells. This makes it easier to spot cancer and even differentiate between benign and malignant lesions. P is more sensitive and specific than CT for many cancers, like non small cell lung cancer, NSCLC, where it can find hidden metastases that could change the treatment plan. PET can also be used to track how well chemotherapy drugs are reaching the tumor, which might help doctors decide on the right dose for a patient. PET's ability to measure blood flow, tumor perfusion, and tissue oxygen levels gives a deeper understanding of the tumor's environment, helping doctors make more informed decisions. Lastly, hybrid imaging using combinations like PET-CT or SPECT-CT has emerged as a powerful tool. By combining functional and anatomical imaging, these methods provide a more complete picture of a tumor, improving both diagnosis and treatment planning. So, while all these imaging techniques, MRI, radioisotopes, and PET, have their unique strengths, they often work together to give the most accurate and comprehensive view of a cancer, helping doctors choose the best course of action for each patient. When treating cancer, it's important to have a clear treatment goal. This helps manage expectations for the patient, their family, and the medical team. In some countries, like the UK, it's even required to record the treatment goal in the patient's medical notes. The treatment goal could be to cure the cancer or to provide palliative care, depending on the stage of the disease and other factors. Palliative chemotherapy is given to patients with advanced cancer, especially those with widespread metastasis, cancer spread. The main aim here is to improve the patient's symptoms and quality of life. Survival is secondary, and the focus is on making the patient feel better rather than curing the disease. This type of chemotherapy should be well tolerated, meaning it should cause minimal side effects. Adjuvant chemotherapy comes after a surgery or other treatment meant to remove the bulk of the cancer. Once the visible tumor is removed, chemotherapy is given to kill any tiny cancer cells that may still be present and invisible to the eye. The goal is to increase survival and reduce the chance of the cancer coming back, improving both disease-free survival and overall survival. On the other hand, neoadjuvant chemotherapy is given before surgery or other treatments. The idea here is that chemotherapy can shrink the tumor enough to make the surgery easier and more effective. It can reduce the size of the tumor, making it easier to remove, and also improve the patient's general health so they can tolerate surgery better. This approach is helpful in studying how the tumor responds to treatment and can provide valuable research data for future treatments. Chemoprevention is a strategy used in people who are at high risk of developing cancer. It involves giving medications to prevent cancer from developing in the first place. These medications are designed to reduce risk without causing significant side effects. When it comes to the treatment approach, doctors must decide how often chemotherapy should be given. Typically, chemotherapy cycles are 21 or 28 days long, and a treatment plan might involve up to 6 cycles. The goal is to find a balance between effectiveness and side effects. Sometimes, changing the approach can increase the effectiveness of treatment, but may also raise the risk of side effects. Low dose therapy is commonly used for palliative chemotherapy. The doses are lower, and the treatment is given after the patient's bone marrow has recovered enough to tolerate it. This approach is less likely to cause severe side effects. High dose therapy uses a larger amount of drugs to kill more cancer cells, but it can cause more damage to the bone marrow. Doctors may use drugs like GCSF to help the bone marrow recover faster. Dose dense therapy involves giving smaller doses of the drug more frequently, like weekly. This helps increase the cumulative dose over time, which can lead to better results. It can also be helpful when the cancer isn't responding well to a more spaced out treatment schedule. Finally, alternating therapy is often used for blood cancers, like leukemia. This method uses different drugs in a rotating pattern to target various types of cancer cells. This helps treat cancer more effectively by overcoming resistance to individual drugs. In summary, the goal of cancer treatment and the approach used depends on the stage of the cancer, the patient's overall health, and the type of cancer. Understanding these treatment strategies helps guide doctors in providing the best care for their patients. When treating cancer, doctors often give the highest dose of treatment that the patient can tolerate. Unfortunately, side effects or toxicity are common, and it's essential to measure and track these reactions. To do this, the Common Toxicity Criteria (CTC) scale is used. This scale rates the severity of side effects from cancer treatments on a 4-point scale, which helps doctors objectively assess how the treatment is affecting the patient and make adjustments when needed. This information is continually updated, and you can find the latest version on the National Cancer Institute's website. In assessing how well a cancer treatment is working, several factors are considered. These include overall survival, remission rates, disease-free survival, response to treatment, and treatment toxicity. These are measured using standardized criteria like RECIST, Response Evaluation Criteria in Solid Tumors. Sure. This system helps doctors communicate effectively with patients about the effectiveness of the treatment, the prognosis, and the side effects they might experience. Overall survival is one of the most important measures. It's the percentage of patients who are still alive after a certain period of time, often reported as a 5-year survival rate. This tells us how many people are alive 5 years after their diagnosis or treatment. Remission rate refers to the percentage of patients whose cancer is no longer detectable after treatment. There are two types of remission. Complete remission means all signs and symptoms of cancer have disappeared, although microscopic cancer might still be present in the body. Partial remission means that some, but not all, signs and symptoms have disappeared. Disease-free survival is the length of time after treatment during which a patient remains cancer-free and without symptoms. It's often used in clinical trials to assess how effective a treatment is at preventing the cancer from coming back. When evaluating a patient's response to treatment, doctors follow RECIST 1.1 guidelines. These guidelines focus on measuring and documenting tumors, especially those that can be clearly identified and measured, like using CT or MRI scans. Doctors measure the longest diameter of target lesions, tumors, and track their size over time to see if they shrink with treatment. To define measurable disease, there must be at least one tumor lesion that can be accurately measured. A lesion must be at least 10 millimeters in size on a CT or MRI scan, or 20 millimeters on a plain X-ray to be measurable. Some cancers may have non-measurable disease, which could include more subjective markers like tumor markers in the blood, ascites, fluid buildup, or effusions, fluid around organs. Residual disease refers to cancer that remains after treatment. If there's any remaining disease, it suggests that the cancer may be resistant to the treatment. This is a negative sign for prognosis. Sometimes, distinguishing between residual disease and normal tissue is challenging, especially after surgery, so additional tests like a fine needle aspirate or biopsy might be needed to confirm the status of the cancer. In summary, the goal of assessing cancer treatment is to track how well the patient is responding while keeping a close eye on side effects. Standardized measures like RECIST, overall survival, and remission rates allow doctors to make informed decisions and help patients understand their treatment outcomes. Surgical oncology has a long history, dating back to ancient Egypt, where the first descriptions of cancer being managed surgically were recorded. Today, surgery remains a critical part of cancer treatment. Surgeons not only assist in diagnosing and staging cancer, but also play a key role in treatment planning as part of a multidisciplinary team. One important aspect of cancer management is prevention. For patients with genetic predispositions, certain surgical procedures can reduce the risk of cancer. For example, patients with familial adenomatous polyposis, a condition that increases the risk of colon cancer, may undergo total colectomy to remove the colon. Women with BRCA1 or BCA2 gene mutations, which increase the risk of breast and ovarian cancers, might opt for bilateral mastectomy and oophorectomy to remove both breasts and ovaries. Similarly, patients with multiple endocrine neoplasia, which increases the risk of thyroid cancer, may have their thyroid removed through a thyroidectomy. Before starting treatment, biopsy is essential to confirm the diagnosis of cancer. A biopsy involves taking a small sample of tissue from a suspicious mass for analysis. The surgeon must choose the correct biopsy method based on the location and type of tumor. There are several types of biopsies. Fine needle aspiration, FNA. This is a quick, minimally invasive method that uses a thin needle to remove a small sample of tissue. It's commonly used for lumps in areas like the breast, lymph nodes, or liver. FNA is highly accurate, over 90% sensitivity and specificity, but may not be suitable for all types of cancer, such as lymphoma or pancreatic cancer. Needle core biopsy. This method uses a special cutting needle to remove a core of tissue. It's often used for tumors deep inside the body, such as in the abdomen, and can be done with imaging guidance. It gives a more detailed sample compared to FNA. Incision versus excision biopsy. If an open surgical biopsy is necessary, excision, removing the entire tumor, is preferred, as it provides better information for staging the cancer, especially in cancers like melanoma or lymphoma. However, in some cases, incision, removing just a part of the tumor, may be safer, especially when the tumor is fixed or when previous treatments like radiation have caused fibrosis. Punch biopsy. This involves removing a small piece of tissue from a superficial tumor. It's useful for certain types of skin cancers, but doesn't give enough information about the structure of deeper tumors. Staging is an essential step in cancer treatment, as it determines how far the cancer has spread. Staging is usually a combination of clinical, radiological, surgical, and histological tissue assessments. In the past, surgeons used invasive procedures like staging laparoscopy or mediastinoscopy to directly assess cancer spread. However, PET-CT imaging is now more commonly used to avoid the risks and recovery time associated with surgery. In summary, surgery plays a vital role in cancer diagnosis, prevention, and treatment. From preventive surgeries to biopsy techniques and staging, surgeons are essential in managing cancer, often in collaboration with other specialists to provide the best care for the patient. Surgical treatment for cancer is mainly aimed at curing the disease by removing the tumor entirely with a healthy margin of normal tissue. This is possible when the cancer is confined to one area, like early stage cancers in the bowel, stomach, or skin. For example, surgeries like gastrectomy, removal of the stomach for early gastric cancer, or radical nephrectomy, removal of the kidney for kidney cancer, can be curative. One important aspect of surgery is the removal of lymph nodes. Lymph nodes are small structures that can harbor cancer cells once the cancer spreads. By removing them, surgeons can help stage the cancer and reduce the risk of further spread. However, this can sometimes lead to a condition called lymphoedema, where swelling occurs due to blocked lymph flow. This is a potential side effect that must be carefully managed. In some cases, a less invasive approach is used, like sentinel lymph node biopsy. This procedure identifies the first lymph node that cancer is likely to spread to. If this node is clear, it can prevent the need to remove other lymph nodes, which can help reduce complications. The sentinel node can be located using a dye or a radioactive substance injected into the area of the tumor. For patients with local recurrence, cancer that returns in the same area, further surgery may be an option. Removing the recurrent cancer can help control symptoms and improve survival, but this must be carefully considered for each patient. There's been a shift away from extensive, mutilating surgeries, favoring less invasive treatments. A multidisciplinary team, MDT, meeting is often held to discuss the best approach for each case. Surgery can also be used to treat metastases, cancer that has spread to other organs. If there are only a few metastases, particularly in the lungs, liver, or brain, surgical removal may improve survival and quality of life. However, surgery for metastases is not always appropriate, especially if the cancer has spread too widely. Another important aspect of cancer surgery is reconstruction. After surgery, especially for cancers like breast cancer, reconstruction can help restore both the physical form and function of the affected area. This can be crucial for a patient's psychological well being, helping them feel more confident and improving their quality of life. Lastly, palliative surgery is used to help patients who may not be curable but still need relief from symptoms. This can include creating a permanent access point for chemotherapy, draining fluid buildup like ascites, or relieving obstructions in the digestive or urinary system. These procedures can significantly improve comfort and the quality of life for patients in the advanced stages of cancer. Chemotherapy has its roots in the use of mustard gas during World War I. While it was used as a chemical weapon, doctors noticed that it caused a reduction in white blood cells in exposed soldiers. This led to the first use of chemotherapy in the 1940s, with nitrogen mustard used to treat lymphoma. Though it temporarily put the cancer into remission, the patient eventually died from bone marrow failure. Chemotherapy uses drugs to kill cancer cells. These drugs can target both primary tumors, where the cancer started, and metastases, spread to other areas. The way chemotherapy works is by affecting the cell cycle, which is how cells grow and divide. There are three main ways chemotherapy drugs act. One, altering the chemistry of nucleic acids, DNA and RNA. Two, interfering with DNA or RNA synthesis, the process of copying genetic material. Three, disrupting cell division, stopping cells from multiplying. One thing to note is that chemotherapy drugs aren't selective. This means they affect not only cancer cells, but also normal, healthy cells that are rapidly dividing, like those in hair follicles, bone marrow, and the lining of the digestive tract. This can cause side effects like hair loss, low blood counts, and digestive problems, which limit how much of the drug can be given and how often it can be repeated. Chemotherapy is often given in combination with multiple drugs, and it's usually delivered intravenously. Treatment is given on an intermittent basis, meaning there are breaks between cycles. A typical cycle lasts 21 to 28 days, and patients usually undergo about 6 cycles. The reason for the breaks is that cancer cells don't repair themselves as quickly as normal cells. By giving chemotherapy in cycles, doctors allow the normal cells time to recover while still attacking the tumor cells. The dose of chemotherapy is often based on the patient's body surface area, which is calculated from their height and weight. This helps doctors figure out the right amount of the drug to administer. Chemotherapy's effectiveness is closely linked to how well the body handles it. That's where pharmacodynamics, what the drug does to the body, and pharmacokinetics, what the body does to the drug, come in. For example, kidney and liver function can affect how the drug is cleared from the body, and this is why doctors monitor these functions carefully during treatment. Despite being effective, chemotherapy is toxic and can cause severe, life-threatening side effects. This is why it's given under the supervision of specialists, and patients are carefully assessed before starting treatment. A patient's fitness level plays a big role in how well they'll tolerate chemotherapy. Those who are less fit are more likely to experience severe side effects. To assess this, doctors use performance status scales, such as the ECOG or Karnofsky scores, to help guide treatment decisions. These scores help determine if a patient is well enough to undergo chemotherapy and how much of a dose they can handle. Growth fraction refers to the percentage of cells in a tumor that are actively dividing at any given time. This is an important concept because cancer treatments like chemotherapy tend to target cells that are dividing. In some cancers, like Burkitt's lymphoma, more than 50% of the tumor cells are actively dividing, which makes these tumors highly sensitive to chemotherapy. These tumors can even double in size every 24 hours. On the other hand, in cancers like adenocarcinomas, the growth fraction might be very low, and these tumors may take months to double in size. Chemotherapy agents are classified based on their relationship to the cell cycle, which is the process of cell division. There are two main types. One, cell cycle dependent drugs. These drugs are most effective against cancer cells that are actively dividing. They can be further divided into phase nonspecific drugs. These work against cells in any phase of the cell cycle except the G0 phase, where cells are not actively dividing. Phase-specific drugs. These only work on cells in a specific phase of the cell cycle, making the timing of treatment important. Two, cell cycle independent drugs. These drugs can act regardless of the cell cycle phase and tend to be effective against both actively dividing and quiescent resting cells. This classification helps doctors design chemotherapy treatment schedules that maximize effectiveness by targeting cells at the right time in their cycle. However, quiescent or resting cells, those in the G0 phase, are not dividing, and most chemotherapy agents don't affect them. These cells can contribute to tumor survival, meaning that for a cure, it's important to eradicate all the malignant cells. Interestingly, some cancers may also trigger a host immune response that can help chemotherapy kill more cancer cells. When we think about tumor growth, it's often described by an exponential model early on, where the tumor doubles in size quickly. But as the tumor grows larger, the growth rate slows down. This is because the tumor starts facing limitations due to its microenvironment, like lack of oxygen or nutrients. Larger tumors tend to have smaller growth fractions, making them less sensitive to certain chemotherapy drugs, especially those that are phase specific. Smaller tumors or micrometastases, small areas of spread, are often more sensitive to chemotherapy, which is why chemotherapy is often given as adjuvant treatment after surgery to target any remaining cancer cells. Most chemotherapy drugs follow a dose response curve, meaning the higher the dose, the more cancer cells are killed. However, the response can be influenced by factors like dose intensity or how frequently the drug is given. Unfortunately, over time, drug resistance can develop. Resistance may be innate, present before treatment, or acquired, develops during treatment. The bigger the tumor or the more times the cancer cells have divided before treatment, the more likely drug resistant cells will be present. This is where multi-drug resistance comes into play, especially when a cancer cell becomes resistant to several drugs after exposure to one. This often happens due to an increase in a protein called P-glycoprotein, which acts like a pump, removing the chemotherapy drugs from the cancer cells. To overcome resistance, doctors often use combination therapy, which involves using multiple drugs to target cancer cells in different ways, making it harder for resistance to develop. In summary, chemotherapy works best when it's tailored to the tumor's growth characteristics and the specific drugs being used. By understanding tumor growth, drug mechanisms, and resistance, doctors can plan more effective treatments for cancer patients.